Hi, my name is Dr. Jorge Plutsky. I'm the Director of Preventive Cardiology, which includes our lipid clinic at the Brigham and Women's Hospital. It's a pleasure to be talking to you about hyperlipidemia today. My disclosures are shown here, and my planned agenda is outlined here. I have more slides I've provided you than I'll have time to present, but hopefully that'll serve as a resource for you. This is a large and complex topic, a lot of very exciting developments in this area over the last 10 years, and they keep coming. I'm going to approach this both in terms of clinical relevance that we all encounter in our practices, whether it's internal medicine or cardiology or any other subspecialty of medicine, and also try and touch on some points related to board or board reexamination. I'm going to overview some of the physiologic pathways that create a context for this, talk about a couple of the key genetic disorders that you encounter clinically and that can come up on boards, then try and get through treatment of cholesterol and lipid disorders in terms of different drugs, some of the landmark clinical trials that create important context for us in treating patients, how those have informed guidelines. And then a couple of the clinical issues that continue to push the field forward, including statin intolerance, some of the new agents that have just arrived, and then also just touch briefly on some emerging risk factors. So here's that complex picture that creates a flashback to medical school for many of us, but it's really quite straightforward. The cholesterol transport system allows these critically important molecules to be circulated in the bloodstream, and we send out cholesterol and triglycerides through VLDL particles. These VLDL particles do contain a lot of triglycerides, and the body, using lipases, strips away those triglycerides, leaving a cholesterol-enriched particle, which is LDL. That LDL is taken up by the LDL receptor. Another source, of course, of cholesterol is what we eat, dietary cholesterol, and then bile, which helps us digest foods, is also made up of a lot of cholesterol. We absorb those critical nutrients along with triglycerides in the form of chylomicrons. So that's the second triglyceride-rich particle, chylomicrons. Once again, the body strips away the triglycerides and the fatty acids that are so essential, and leaving a cholesterol-rich particle, which are the chylomicron remnants. And then the second pathway we'll touch upon is reverse cholesterol transport, which is through HDL. The signature apolipoproteins for these particles, where they really act as zip codes telling the particles where to go. So ApoB is the VLDL and LDL particles. ApoA1 is sort of a signature, you can think of it, for HDL. And here's HDL, and what it does, the shorthand is that it does reverse cholesterol transport. It helps move those cholesterol-containing particles back to the liver. HDL starts out as a disc and then basically drinks up cholesterol, and at some point detaches from the blood vessel wall and returns to the liver, where it can bind and return that. So this is a reverse cholesterol transport moving back to the liver. And then the third topic is triglycerides and triglyceride metabolism. So triglycerides, just like tri and tricycle, are three fatty acids attached to a glycerol backbone. And we strip away those fatty acids using lipases. And those fatty acids are used either to burn for energy, or they are stored in fat and provide essential resources for survival. A lot of interesting complex biology about fatty acids. And as mentioned, the main sources are VLDL from the liver and chylomicrons from the gut. So let's dive into this area, and we've really seen just tremendous progress. This was the first, one of the landmark studies that pointed to the importance of cholesterol, which was in the late 1950s, Ansel Keys, showing that no matter where you lived in the world, higher cholesterol levels was associated with cardiovascular mortality and cardiovascular events. And that really set up this concept that perhaps lowering someone's cholesterol levels would decrease their cardiovascular risk. That's most evident in some of these genetic disorders, and the one that really informs us is to think about what happens when in the scenario of familial hypercholesterolemia, or FH. Here is sort of a summary about homozygous FH. And homozygous FH, of course, there are two mutant alleles that have come from each of the two parents. You can have differing amounts of LDL receptor activity. That's where the genetic defect occurs. And people who are homozygous FH can have total cholesterol levels greater than 500, LDL levels in the 300 to 600 range. And they can even have a cardiovascular event or heart attack as young as 1. And so really establish on a genetic basis the relationship between LDL and cardiovascular risk. And there are more and more treatments becoming available. Here's that LDL receptor I talked about. And down here in this blue bar is the cell membrane. This LDL receptor sticks out into the blood and interacts with LDL particles as shown here, binds that LDL and brings it into the cell. And there are many steps in this uptake of LDL, and you can have genetic variants in each of these steps. So you can have LDL receptor defective function and then complete loss of LDL function. And these variabilities can impact how patients respond to treatments if they're LDL receptor dependent, as many of our treatments are. You may not have seen a patient with homozygous FH, but I can tell you that you very likely have seen one with heterozygous FH. It's only 1 in 500 people who can show up with heterozygous FH, actually particularly common in certain places like New England due to a founder effect phenomenon. FH is diagnosed through the presence of tendinous xanthomas, as I'll show you. When you see a patient with very elevated LDL levels, you always have to check a TSH and make sure they don't have a liver disease. But this heterozygous FH is associated with increased risk of cardiovascular events. And just to underscore here, the diagnosis of FH is a clinical one. So you don't have to send off for genotyping, although that's becoming more and more available. But even getting approval for medicines like PCSK9 inhibitors does not require genotyping. So here you see pictures of those tendinous xanthomas. So on the extensor surface of tendons, these can be found, including like the Achilles tendon. And a pattern that shows a very high LDL and that also being seen in first-degree relatives or the presence of early clinical events can contribute to diagnosis of FH. I put a picture in here of a xanthelasma at the bottom. That is not part of FH, this deposition of cholesterol around the eyes. That can occur completely independent of FH. And although we think of FH as being mainly due to defects in the LDL receptor, the fact is that there are 3 other places where you can also see a clinical phenotype that looks like FH. It's really quite similar to it. And I've listed those here. We'll return to that. On the board, you may be shown a picture of pathognomonic signs of lipid disorders with very high triglycerides like type 3 hyperlipidemia, defects in the LPL enzyme that hydrolyzes those triglycerides and gets them off VLDL, then the triglyceride levels can accumulate. So eruptive xanthomas, triglyceride deposits in the skin, or yellowish crease in the palm of Palmer xanthoma can be occluded that. And for HDL, one of the ones that shows up on boards is Tangier's disease, or people with very low HDL. The defect is the ABCA1 receptor for HDL, and the classic finding are these orange like tonsils that might come up. So in terms of treatment, really, the statins have really remade our approach to preventive cardiology and reducing cardiovascular risk. And so this slide captures a lot of that data. This is showing the placebo and treated groups in trials with secondary prevention. So 4S was the first trials I'll show you, placebo untreated to treated, and on down to people with lower and lower risk. And then the yellow is the primary prevention line. Not as steep, but still showing this significant trend to lower LDLs being associated with lower event rates. And this has really been quite a triumph for us. And just to step through those, here's 4S. So these are individuals who had LDLs of 190 in a prior heart attack, and simvastatin 20 or 40 milligrams led to a 30% decrease in mortality. That's really as tough of a standard as a clinical trial can have. So the results here were very impressive, demonstrating statins could reduce cardiovascular events, LDLs of 190 in a prior MI. And this trial didn't enroll people until they were 6 months out after a heart attack or bypass. And the other end of the spectrum, here's primary prevention, the AFCAPS trial. So this is LDL lowering in people. I don't refer to them as patients. They had not had cardiovascular events. Did include men and women. LDLs were about 150 on average. And lovastatin also showed the statistically significant decrease in events through the use of a statin. Importantly, as we started wrestling with guidelines, only about 70% of people in AFCAPS would have met the guidelines in place at that time. Now, of course, we pushed on into other landmark trials, and one I want to highlight is PROVE IT in acute coronary syndromes. The question of would a lower LDL be better in a high-risk population of people who just had an MI. So this compared two active therapies, pravastatin 40 milligrams, which had already been shown to have clinical benefit, and atorvastatin 80 milligrams, which at the time the study was done, had not yet had a positive trial. The LDLs achieved were 95 versus 62 in these people who had just had an acute coronary syndrome. And here you see the event curves. So statistically significant 60% reduction in events. This is why all patients in the hospitals that you work at are getting atorvastatin 80 milligrams after an acute coronary syndrome, no matter what their baseline LDL was beforehand. Now, even with this positive trial, here's what we refer to as residual risk, that even the people who got the atorvastatin 80 in this very well-treated population who had LDLs of 62 still had events at a significant rate. So made it lower was better, but there's still ongoing events, and frames those questions of, well, how else can we continue to do better than this? One of those possibilities is the attention focused on all that cholesterol that fluxes through the gut. And could you not block that absorption and lower cholesterol levels that way? And one treatment that extended beyond what we used to use, cholesterol bile acid resins that bind cholesterol in the gut, ezetimibe, inhibits the NPC1L1 transporter and will decrease cholesterol absorption. It will lower LDL an additional 15 to 20% when added to any statin. And we do have clinical trial evidence for it working. This is the PROVE IT study, adding ezetimibe 10 to simvastatin. Here you see that additional sort of 15 to 20% LDL lowering when you add ezetimibe to a statin, and it was a positive clinical trial, significantly reducing events. Ezetimibe is often underutilized. We often see patients in the lipid clinic who are not getting ezetimibe. There had been concerns about cancer. Those did not bear up. And I also want to just mention that we wouldn't tell you to use ezetimibe rather than titrate the statin, but it is still a valuable tool in many different clinical settings. Now, an important new chapter that arose in this cholesterol management story was the identification of people who went through their whole life with lower LDL levels. And as shown here from the Dallas Heart Study, people who had lost function of PCSK9 have lower LDL levels as compared to people whose PCSK9 was intact, had a no-nonsense mutation in PCSK9. And so this allowed the question to be asked, well, okay, what's wrong with these individuals with these lower LDL levels? Do they have problems for that? And it turns out, no, that they were completely normal, completely healthy. The one thing that was found, as shown here on the right, is these individuals with lifelong genetic protection against higher LDL levels, the average LDL in the United States being about 150, these individuals had a much lower risk of coronary heart disease. So raised the question of how do you turn this into a therapy? And remember that in those 4 genes associated with familial hypercholesterolemia, one of them at the bottom here was the PCSK9 protease that we're talking about. But this mutation with high LDL levels is a gain of function. When PCSK9 is overactive, you can see people who look just like they have FH and have high LDL levels. And so that story really bears out. People with gain of function of PCSK9 genetically look like they have FH, have very high LDL levels, whereas loss of function have these LDL levels throughout life in the 50 range, sometimes even lower. And really made a good argument for this maybe being a therapeutic target because you had genetic evidence for it. And what does PCSK9 do? Well, it's shown here in this sort of beige hot dog looking structures that PCSK9 is secreted out of the cell, jumps on the LDL receptor. And when PCSK9 is there, an LDL receptor, rather than going back up to the surface for another round of clearing LDL, PCSK9 targets it for degradation. So you can imagine that if your PCSK9 is overactive on high levels, that you're going to keep degrading your LDL receptors. Whereas if you have a mutation with no PCSK9, then those LDL receptors continue to go back to the surface and clear LDL. And so 2 drugs came forward that are antibodies to PCSK9. One of them is Praluent, and one of them is Repatha. And those have both had landmark clinical trials that I won't go through in detail other than to highlight them here. With Praluent, you have the Odyssey outcomes trials, and with Repatha, you have the Fourier trial. Slight differences between them, but the results are quite similar. They're both positive studies adding these agents to a statin to people who come into these studies with baseline LDLs in the 87, 90 range. And with a PCSK9 inhibitor, you will routinely get a 50% reduction in LDL. And so both very striking and showing benefit. Very well tolerated clinically. Patients may be scared of the needle, but I've had really no patients unable to do these self-injections. And occasionally you'll have someone have an injection site reaction, but they often get used to it and don't have issues with it. An interesting topic out of the PCSK9 story is there a threshold for benefit? In Odyssey outcomes, it did seem that the greatest benefit were those patients who came in with LDLs greater than 100, although this is a secondary endpoint. Whereas in the Fourier study with Repatha or evolocumab, there's benefit seen even among those patients who came in the study with the lowest LDLs. So LDLs, under 70, as you see at the top, benefited as much as those who had LDLs greater than 70. And is really, raises the notion that whereas we evolved to understand that lower LDL was better, these PCSK9 data sort of argues that lowest may be best in the right patients. And that really is fascinating. It lines up exactly with what Brown and Goldstein said in their Nobel Prize lecture in 1985, that physiological levels of LDL in the 25 to 60 range may be what's all that's needed. Now, this ultimately has been incorporated into guidelines. We've seen those guidelines evolve as we've had more and more data. In 2013, a different approach was taken with the guidelines that directed attention to 4 patient groups that benefit from statins and did less in the way, trying to facilitate for clinicians to identify who should be on a statin. So those 4 groups are here. ASCVD, known cardiovascular atherosclerotic disease, LDLs that are greater than or equal to 190, because there's a bigger chance those people have FH, patients with diabetes, and patients whose 10-year risk calculation is greater than or equal to 7.5%, assuming they don't fall into one of those other groups, and that all 4 of these groups should be on statin therapy and treated with the intensity statin that was studied in the trials that established this benefit. This notion has stayed with us in the more recent iteration of the guidelines, is why I pointed out. This guidelines had abandoned LDL targets, but in the new guidelines, as I'll touch upon, this has evolved as well. Here are the most recent guidelines. You have reference for these, and I recommend this as being very valuable reading for anyone. They have been excerpted in executive summaries, but here's the guideline for secondary prevention that will lead you to maximal therapy. And considering PCSK9 inhibitor, if the LDLs are not appropriately achieved, but using ezetimibe before you'd go to PCSK9 because of ezetimibe's proven record, safety, and cost, PCSK9 being more expensive. And there is, as a top line, more attention in these guidelines to personalizing approaches, as you see here with ASCVD, not at very high risk versus very high risk ASCVD in terms of the thresholds, as they refer to them, as you might push on to more aggressive therapy. For us in our approach in secondary prevention, we're often looking for that LDL to be less than 70 and are often aggressive about trying to get it down because of the data around that. And what constitutes very high risk? Well, These are highlighted here. People who've had multiple cardiovascular events or one major event and then multiple high-risk conditions as shown here. The heterozygous FH, diabetes, hypertension, chronic kidney disease, ongoing smoking, LDLs that haven't come down low enough. Primary prevention gets more complicated, of course, because now you're talking about treating people who don't yet have an issue, but that's the real opportunity for reducing events. And it does involve thinking about these patients and what they might have, with there being strong recommendations if the LDL is greater than 190 and they have diabetes, and then some thought about those other scenarios. And keep in mind that guidelines often are based upon what was enrolled in the trial. So a cutoff of the age of 75 is only because that's what was studied in the trials. Your fiber patient over 75 who has diabetes, I would certainly treat. And if someone whose risk is sufficient in primary prevention over 75, I would also treat them and not withhold treatment just because of their age. Risk enhancers are identified in the guidelines, and I've provided these here. These are more subtle sort of judgment issues that can be discussed with patients about trying to determine this gradation of borderline risk, intermediate risk, and high risk. And these guidelines now also note the opportunities of using a coronary artery calcium scan if there's someone that you're not sure about what category they're falling in as a way of deciding about treatment. And these risk enhancing factors I just highlight here again more completely. And this is where the guidelines get into more of those gray areas of other factors that we're still learning about, but that can be incorporated into your approach of treating such patients. Now, let's just talk a little bit about those clinical issues that continue to emerge. One of those that we get asked about a lot, and is actually about maybe 40% of the patients referred to the lipid clinic, is questions of statin intolerance. That can be increased liver function tests or increased muscle enzyme numbers, CK. Just want to highlight that in prior guidelines, there was guidance that you really didn't have to stop a statin if the LFTs were less than 3 times the upper limit of normal, with there often being more benefit than any specific concern about modestly elevated liver function tests. And then for CKs in the asymptomatic patient, you could tolerate up to 10 times the upper limit of normal. Myalgias is probably the biggest reason why patients get referred for statin intolerance, and they may or may not have CK elevations. Interestingly, in clinical trials, it's been about 5% of subjects would have an issue with a statin, have to stop it, whereas in the real world, that number is higher, maybe 15 to 20% for reasons that we don't completely understand. Importantly, the risk of a serious adverse event like rhabdomyolysis is quite rare, and it can be helpful for the boards and also for your clinical practice to know what some of those interactors can be, often antibiotics, older HIV medications, less so with the current ones. Higher doses of statins. We no longer use simvastatin 80 milligrams because of that. Can all be relevant. But just to put this in context, if you go back to that Forest trial of a statin in people with an LDL on average of 190 in a prior event, actually more people quit the placebo than quit the statin. It wasn't statistically significant, but highlights this issue. And as the PCSK9 inhibitors came along, there's some interesting studies trying to address issues of statin intolerance, because you might want to argue that maybe PCSK9 should be used in statin intolerance. And the GAUS-3 study took a very interesting approach to statin intolerance in a small group of patients, around 500, where they underwent a run-in of receiving in blinded fashion either Atorva 20 or placebo for 10 weeks, then crossing over to either Atorva if you had the placebo first, or from Atorva to placebo for another 10 weeks. And the only people who get into the trial of giving a PCSK9 inhibitor or ezetimibe are those who have the correct responses in terms of symptoms, meaning that they reacted to the statin but didn't react to the placebo. And when you do that, it's interesting that you had many, many patients who could tolerate the statin but not the placebo, about 43%. And some people who had a reaction to the placebo and not the Atorva, or to both of them. And so the only people who would have qualified for the study were the first group who reacted to the atorvastatin, not the placebo, that 43% group. And the other ones actually didn't have statin intolerance given this pattern. So what we usually say in clinic is that we highlight to patients from the perspective of advocacy that may not be the statin. We use education to help explain to them why someone wants them to be on a statin, the potential benefits. It may be dose related, although the trials don't always show that, but we will, in the appropriate patients, start with the lowest dose, even cutting a pill in half, starting Monday, Wednesday, and Friday. This is really anecdotal sort of clinical approaches. And that people may have statin-specific reactions where they don't have an issue, where they have issues with some statins, but not another one that you try. And so we often will go to rosuvastatin and perhaps even Livalo, pitavastatin, a newer statin from Japan that's still not generic, which may have greater tolerability. There's not good evidence for maneuvers that will allow patients to tolerate a statin, but anecdotally, some patients do better when you give them CoQ10, and we often give it to them before they start the statin. And for many of those patients, they decide it's not what allowed them to tolerate the statin. It may be a combination of any of the above, a different statin, and education for why they'd want to be on the statin. A placebo test is an option in terms of giving someone ezetimibe. Ezetimibe, there's no reason for someone to have the same myalgias with ezetimibe and a statin. Often patients think ezetimibe is a statin, and so revisiting that can be a good idea. And for the patient who truly can't take a statin, you have PCSK9 as an option, along with other ones. Triglycerides has been a complicated issue. There's been longstanding evidence that in the patients with the same LDL, that those with higher triglycerides may have more risk. They will have higher ApoB levels, small, dense LDL. For boards, you always want to, and for patients, you always want to run through the list of secondary causes of high triglycerides, making sure there's not protein spilling in the urine, that the TSH is normal. Think about drugs that can raise triglycerides, in particular hydrochlorothiazide. Whether their diet has them having too much in the way of carbs, whether they have diabetes that's inadequately controlled or not been diagnosed, excess alcohol intake, obesity may all contribute to that. But often when you work through this, you can get a 50% reduction in triglycerides. Even with modest amounts of weight loss, modest amount of increased activity can have quite an impact on this. Omega-3 fatty acids are a treatment for hypertriglyceridemia. There are different kinds of omega-3 fatty acids. Usually the active ingredients for triglycerides have been considered to be EPA and DHA. We now have a new landmark clinical trial looking at a specific kind of fish oil, EPA, specific kind of omega-3 fatty acid in terms of icosapent-ethyl, known as Vascepa. And here's the trial for that in basically 8,200 patients. And this had a very impressive positive outcome, 25% relative risk reduction, adding it on to a statin. And so Vascepa is an alternative and has data supporting it. The fibrates have not had as clear-cutted data. There's been secondary endpoint data that's been positive. One trial with gemfibrozol, which we tend not to use because it has more issues with statin interaction, was positive, but Vascepa was very impressive. So I encourage you to think about the use of Vascepa in your patients with hypertriglyceridemia who've not responded to the other measures and when the risk is higher. Its approval is now better that it has label for decreasing cardiovascular events. Bempedoic acid is another new therapy that's arrived. Bempedoic acid works in the same pathway as statins, but upstream, and the enzyme that will convert bempedoic acid to being active is only present in the liver. And so the notion that maybe there'd be less in the way of issues as happens with a statin. Bempedoic acid is available alone, and it's also available in combination with ezetimibe. And you can get particularly significant LDL lowering with bempedoic acid alone, but also in combination with the ezetimibe, where you can get close to 50% LDL reduction. The clinical trial for that is underway. So I encourage you to start thinking about bempedoic acid as another alternative for people who are not getting to the right LDL numbers. PCSK9 inhibitor would still be our first choice. If you can get it approved, that's also easier. But when you can't, it is an alternative. and including an alternative for people with statin intolerance. We're waiting for the clinical outcome trials for that. And so using a statin intolerance as a possibility may have an effect through inflammation and CRP, but we're waiting for the trial. So I encourage you to start thinking about that. In terms of emerging risk factors, I'm just going to touch on one. Lipoprotein little a, LP little a, is structurally related to LDL, but has this extra apolipoprotein A and a bridge associated with it. We have more and more evidence of it being associated with risk in epidemiology. Mendelian randomization, genome-wide association have all argued that LP little a matters. We've just not had a therapy for LP little a lowering. So I would only check it if there's a reason, like premature coronary disease or a strong family history, but otherwise I wouldn't check it. But in those situations, I would. And what do we do with LP little a? Well, we're waiting for therapies. We often use statins to lower that LDL, maybe lowering it even lower than we would otherwise be targeting. PCSK9 inhibitors can lower LP little a, roughly at 30%. Niacin lowers LP little a, but has failed in clinical trials, so we don't do that. And here's just an example of the data that suggested that LP little a lowering with PCSK9 inhibitors may additionally contribute to reducing risk. And so you see here in the Fourier trial, when the LP little a was greater than the median, there was a 23% reduction, whereas when LP little a was less than the median, it was a 7% reduction. So that's really a whirlwind tour of all the exciting developments in terms of lipids and cholesterol. I encourage you to go and starting with the guidelines, but also considering some of these other issues. Some references are provided here, and I appreciate your attention. I'm going to go through a couple of questions as well about some of the topics we talked about in just a moment. So one of those that I think is helpful to know and to think about are secondary drivers or hypertriglyceridemia and what is on that list. Nephrotic syndrome, diabetes, poorly controlled diabetes, hypothyroidism, or all of the above. And the correct answer is all of the above. And as mentioned, thinking about these and intervening on them can often convert the patient with a well-controlled LDL, which is your first line attention, to who still has elevated triglycerides, to improving those triglycerides to the point that they may not need a second agent for that. And here's the second question. Heterozygous familial hypercholesterolemia is characterized by elevated LDL levels, 2 polymerxanthomas, 3 autosomal dominant, 4 low HDL, 5 pancreatitis. And so the usual board kind of 1 and 3, 2 and 4, 1 and 5, 2 and 5 are all the above. So as we go through this, FH is definitely characterized by elevated LDL levels. Polymerxanthomas would be found with hypertriglyceridemia if that's on a genetic basis. FH is autosomal dominant. It is not associated with low HDL. Pancreatitis is a complication of severe hypertriglyceridemia. In cases with severe hypertriglyceridemia and pancreatitis, first-line therapy would be a fibrate as a more directed triglyceride intervention, since hypertriglyceridemia can actually cause pancreatitis. So the correct answer here would be 1 and 3. Many interesting questions and more to learn about cholesterol and lipids. I hope this has been useful to you, whether it's for the boards or for your own practice. Always available if there are any questions, if someone wants to email or to follow up further. Thank you for your attention.